early abdominal pregnancy challenges, update and review of current management. So last time that was an overall discussion about the ectopic pregnancy and the tubal ectopics, and today what we are discussing mainly non-tubal ectopic pregnancies. Okay, and these are the talk articles we are discussing. So third talk article is about early abdominal ectopic pregnancy. What are the challenges, update and review of current management. So what is the definition? Occurs in the abdominal cavity excluding the tubal and ovarian pregnancies. So here the tubal and ovarian pregnancies are excluded. The pregnancy is in the abdominal cavity. So early abdominal ectopic pregnancy is rare but associated with high mortality. Symptoms are similar to other ectopic pregnancies. High index of suspicion is crucial for diagnosis. Ultrasound is the preferred diagnostic tool, and when combined with clinical evaluation, ultrasound accuracy is only 50%. Again, this is one of the ectopic where the beta hCG value may not be helpful. Another ectopic where beta hCG will not be much helpful is a heterotopic pregnancy. Okay, even sometimes in interstitial also it may or may not help. Okay, so these are a couple of things which may help you to understand the scenario better. Okay, and the typical ultrasound findings which are given to you. Okay. Now, implantation sites. Up till now, they have not asked about this, but the implantation sites, what is mentioned is a uterine serosa, pouch of Douglas, omentum, bowel, mesentery, mesosalpinx, pelvic and abdominal wall peritoneum, liver, spleen, diaphragm, gyrotas fascia. These are the sites which they have mentioned. But if they ask the common site, then what to choose? Whether it is uterine serosa or whether it is a pouch of Douglas. Really, there is a confusion between the two. But what the same article mentions, locations of abdominal pregnancies. There is a study by Pule et al. It is a 45-year review of 225 early abdominal pregnancies. Okay, so they have studied 225 ectopic pregnancy, and pouches surrounding the uterus, there were 55 cases, primarily in the pouch of Douglas. There were 55, and seros of the uterus and adnexa were 54. So almost similar. So I don't know what option will be given if at all the question is asked, but as per this particular study, what we feel is a pouch of Douglas. But sometimes if they go sequentially, if this is arranged as per the prevalence, that I do not know, but there might be some confusion between the uterine serosa and pouch of Douglas. But what does this study says is the pouch of Douglas, 55 cases. Okay, the incidence is around 1% of ectopic pregnancies, and overall it is around 1 in 2200 to 10,200 pregnancies. Mortality is 7.7 times higher than the tubal pregnancy and 90 times higher than the intrauterine pregnancy. So these abdominal pregnancies are at a very high risk of mortality, 7 times higher mortality than the tubal ectopic and 90 times higher than the intrauterine pregnancy. Overall, just 1% of all ectopic will be abdominal ectopic. Okay, around 1 in 2200 to 1 in 10,000 cases. And most of the time the diagnosis is missed. Only 1 in 9 cases will be correctly diagnosed before this pregnancy. Remember, see, often missed preoperatively. Only 1 in 9 cases correctly diagnosed before surgery. Early diagnosis and intervention are crucial to reduce mortality. ART use is increasing ectopic pregnancy, but not for the abdominal pregnancy. This also I have discussed. ART increases the prevalence of all the ectopic pregnancies, but the incidence of the abdominal ectopic pregnancy has remained constant in spite of ART. Okay, mortality trend has improved over a period of 20 years, so it has reduced mortality from 20% to less than 5% due to early intervention. Now, how to classify these abdominal ectopic pregnancy? They are classified by two ways. One, by gestational age. It can be early abdominal pregnancy when the it is less than 20 weeks of gestation at the time of presentation, less than or equal to 20 weeks of gestation. Or it can be classified as a late abdominal pregnancy when it is more than 20 weeks of gestation. By implantation, it may be primary abdominal or it may be secondary abdominal. What we mean by primary abdominal, it is an implantation directly on the abdominal organs, excluding the tubes and ovaries. Okay. Then what do you mean by secondary? Initial implantation is in the reproductive tract, later implanted in abdominal. Okay, so there may be tubal abortion, but it gets implanted into the some other organ and it continues. The secondary abdominal pregnancies occur births, and per se this classification, is there any clinical relevance? Classification is more academic. It rarely affects the management. We should just know from academic point of view, was it a primary abdominal pregnancy or secondary, and from management point of view we can because early abdominal, ectopic and late will have different management. So from management point of view, the gestational age classification may be useful. Okay, these are the criteria not asked in the examination, but just we'll rush through. There are study force criteria in which normal tubes and ovary. We have mentioned that when you diagnose abdominal pregnancy, it doesn't include tubal or ovaries. Okay, there is no injury, then no uteroperitoneal fistula. Pregnancy is confined to the peritoneal surface. Diagnosis is made early. Rules of secondary implantation. Then there are Friedrich's criteria, in which you have gestational age less than 12 weeks and trophoblast attached only to the peritoneum. Okay, here there is a direct attachment of the trophoblast to the peritoneum. Okay. So these are the diagnostic criteria. Then what are the risk factors for early abdominal pregnancy? They are same as other ectopic pregnancies. Prior ectopic pregnancy or tubal surgery, endometriosis, PID, current intrauterine device use. So these are the high risk factors for the development of the abdominal ectopic. Then IVF related risks are not very common. They are rare, in which what they have mentioned is a uterine perforation during embryo transfer, oocyte migration with abdominal fertilization, microfistulous tract in the uterine isthmus. Okay, despite increased ART use, there is no rise in the abdominal pregnancy incidence. Okay, these ectopic have the prevalence has remained constant. Okay. Now coming to the diagnosis of early abdominal pregnancy. Signs and symptoms: highly variable presentation, no specific symptoms to distinguish early abdominal from tubal ectopic, requires high index of suspicion, often diagnosed intraoperatively at the time of laparoscopy or laparotomy, may require multiple surgeries before correct diagnosis is made. Then investigations: serum beta hCG, suboptimal rise in beta hCG is non-specific and not a diagnostic of ectopic. Beta hCG generally may not help in this ectopic abdominal ectopic. Then ultrasound, first line diagnostic tool, but it has got limited accuracy, only 50% cases when used with the clinical assessment. Critical for identifying location and organ attachment, which guides the management. Okay. So what are the key ultrasound findings suggestive of abdominal pregnancy? There will be empty uterus, G-sac or the fetal parts which are separate from the uterus, adnexa and the ovaries. Mass is seen in the abdomen away from the pelvis, showing pregnancy features, that is the fetal heartbeat, etc. Then no uterine wall between the bladder, fetus and the bladder. So normally when you see on scan on transabdominal, what you see the maternal bladder, you see the fetus, and in between there is a uterine wall. This uterine wall is absent between the fetus and the bladder in this abdominal pregnancy. Then uterus is visible as a separate structure from the gestation. Fetus is close to the abdominal wall and placenta located outside the uterine cavity. So these are the diagnostic features on ultrasound for the abdominal pregnancy. Sometimes there can be diagnostic pitfalls. It may give false positive or confuse the diagnosis, and it may be because of the uterine fibroids, retroflex uterus. Intrauterine pregnancy may give false negative, and the cervical, intramural, cornual and bicornuate pregnancies may be a false positive diagnosis also. So sometimes it can be falsely diagnosed in this particular way. Okay. Then what is the role of MRI? It is useful when the ultrasound is inconclusive, better for mapping the organ involvement than for initial. So you want to know where the placenta is attached. Okay, how is the attachment and all. So it is better for organ mapping organ involvement. Then what about the gadolinium contrast? It crosses the placenta. Generally, it is contraindicated in pregnancy. Okay, but when there is a maternal life at risk, this gadolinium contrast can be used, because anyway, this is not for the continuation of the pregnancy. After that, we are going to terminate the pregnancy. So in this particular case, maternal life is at increase. So in this particular case, gadolinium contrast can be used, but otherwise, gadolinium contrast is contraindicated in pregnancy. Do remember, n number of times this will come when we are studying RCOG study material. Okay. So can be used with consent if the maternal life is at risk, including the possible consent for the termination, and preferably done before surgery to aid planning. Okay, that is what is the role of. Then intraoperative imaging, this is more theoretical. Basically, the condition itself is rare. So what they mention, if uncertainty persists during the surgery, Intraoperative laparoscopic ultrasound or transvaginal ultrasound may assist diagnosis. Okay, so this is something more theoretical which they have mentioned. Then post-operative diagnosis, histology confirms abdominal pregnancy by showing trophoblast proliferation and neovascularization involving the attached organ. Okay. Pathophysiology of ectopic pregnancy, generally pathophysiology will not be asked, so we will not go into the detail. You can read this later on. Then coming to the treatment of early abdominal pregnancy. What are the general principles? High maternal mortality due to implantation on highly vascular surfaces, risk of sudden massive bleeding anytime during the pregnancy. Key factors affecting the management are: one is a maternal hemodynamic status, and second is a gestational age at the time of presentation. Medical management is used when the location is at a life-threatening life-threatening bleeding is anticipated. Say, for example, it is a splenic or hepatic early abdominal pregnancy. We may consider the medical management. The agents which are used are methotrexate, which may be systemic or local, then KCl, hyperosmolar glucose, prostaglandins, danazol, etoposide, mifepristone, etc. What are the limitations? There are no standard guidelines or reliable predictors for success, and often requires subsequent surgery due to the hemorrhage. Then arterial embolization is another way of management. It may be used preoperatively to reduce vascularity and bleeding risk. Also used postoperatively to control the bleeding from retained placenta. Another is surgical management. It requires experienced surgeon and often multidisciplinary team. Expectant management is not safe in the second trimester due to risk of sudden hemorrhage and poor fetal outcome. Immediate surgery recommended once it is diagnosed, especially if the fetus is dead, to prevent infection and DIC. So even if it is a dead fetus, then also the surgery is indicated and as early as possible. So preferred management will be the surgical management. Now only the route of management. What will be the route of management? So historically it was managed by the laparotomy, but nowadays laparoscopy is successfully managing early cases. Hemorrhage control methods during laparoscopy will include bipolar electrocautery, harmonic scalpel, hemostatic agents, then vasopressin, fibrin sealants can be used, and a combination of techniques often required. Then what are the outcomes? Laparoscopic surgery is associated with reduced blood loss, shorter hospital stay, high success in early abdominal pregnancy, especially after 2000. Most of the pregnancies can be managed with the help of laparoscopy. Around 100% laparoscopic rate in after the 2000 they have mentioned, and laparoscopy have been used in hemoperitoneum cases successfully. Okay, so that finishes the third talk article